Hi, everyone. It's Sue, and I want to just take a minute to talk a little bit about work of breathing, and I'm going to talk about it from a nursing perspective. If you see that term, if you do a Google search or look it up, work of breathing is often a calculation that an RT or a respirologist will do that's quite a technical calculation about what happens at a cellular level. I'm not going to talk about that. I'm going to talk about some parameters that are really important when we are assessing our patients. And this short discussion is really going to focus on practice wisdom. So what do we do in clinical? How do we bring all of the things we learn in a very sophisticated way right down to the practice setting? So it's a little bit of that, what do you learn over the course of a career that really helps you to look at your patient in a very critical way, as opposed to what you're going to see in a textbook. Just some thoughts from me. Keeping in mind a couple of things. We all know how to do a basic respiratory assessment. Some tips and some important reminders. It is critical that we do this in a pristine way. It is critical that we assess all lung fields. So from the base all the way up to the apex of our lungs, we're going to make sure that we do a very solid assessment. A reminder that you cannot hear breath sounds at the base unless you have your patient either sitting up, standing up, or if a patient is lying down and not able to get up, we have to turn them on their side. It's so important that we do that. Critical that we also make sure that our stethoscope is right next to a patient's skin, that we don't have a gown in between. You'll see this all the time. It's not acceptable. I know my dear colleague Leslie is appalled that they actually make special stethoscopes that are helpful to hear over close. The only place I would say that that is sometimes a reasonable option is when you're out at the triage desk in the midst of many, many people, and you know that a patient, as soon as you move them somewhere, is going to have a secondary assessment by a nurse. And so you might see that, and Leslie and I both have just different opinions about that based on our experience. But even then, I try to slip a stethoscope down somebody's back underneath their clothes to really make sure I can hear it. There's too much crinkling and other things over clothes, and you just may not hear it, particularly if you have absent breath sounds. You may hear wheezing, you may hear crackles, but when you have absent breath sounds, it's hard to determine if you're hearing just good air entry, good breath sounds, or if they're actually absent. It's also important. So for all patients, we do an excellent respiratory assessment. For the NCLEX, that final bullet point, they may ask you, like, where do you place your stethoscope? So important. I know in practice we move to a much more rapid process where we're not precise about where we place that stethoscope. I'm sure I am not precise, but for the NCLEX, we do need to be precise. And sometimes they'll actually have an option where you can move the stethoscope and place it on the patient in a visual picture in the right place, or even talk about landmarking. But it's important that you know where to place your stethoscope and to do a really good assessment. But also, just again, coming back to this idea of practice wisdom, we know that certain clients may be at different risk. That doesn't mean we ever cut corners and we don't do a full assessment on every single patient. But for example, if I have a post-operative patient and I know that patient is at risk for atelectasis, not that I don't check every patient pristinely, but that post-op patient, I might spend just even extra time really listening to those bases. Or if a patient, depending on the kind of surgery, has had to be sidelined, I may really listen to the side, because we're looking for those fine crackles in the bases. If I know in the bases of their lungs or in the dependent position. I know that if a patient, for example, already has pneumonia or some other pathological condition, again, I need to assess pristinely everywhere, but I also spend a little extra time so that I have a good insight into what's going on in that region as well as beyond. So for various populations, we really want to take good care in not only understanding how everybody has a pristine respiratory assessment, but how specific patients have that pristine assessment, plus a particular care to a focus. So let's talk about oxygen saturation, and we all know the details. The most important thing I want to say, I'll say it at the beginning and at the end, is that don't over rely on oxygen saturation. It's so important. It gives us good insight, but don't over rely on it. So here are some tips. One, it's important that I tend not to always come back to scientific explanations, but this one we really need to keep in mind. what does that oxyhemoglobin dissociation curve look like? And why do we care about that? And we care about that because oxygen and hemoglobin have sort of a magnetic attraction. And above 90% saturation, that attraction stays fairly consistent. So the attraction of oxygen into that hemoglobin molecule, which is what we want, right? Hemoglobin carries oxygen to all the cells in our bodies. So we want that oxygen to be drawn into that hemoglobin molecule. So from 100% to 99% to 98% to 97%, it slowly becomes just the slightest bit less and less drawn, less and less magnetically drawn. It's not really magnetism, but you understand the metaphor, magnetically drawn into that hemoglobin. And that starts to accelerate a tiny bit, but where it really drops off the cliff is at 90%. So when we hit an oxygen saturation of 90%, suddenly that oxygen is not as magnetically drawn, and that drop becomes very steep. So the difference in that attraction of oxygen to hemoglobin from 95% to 94% or 93% is very small compared to that difference from 90% to 89, 88, 87. That drop off in the attraction of oxygen to the hemoglobin is very significant at that point. And that's why 90% is a really important cutoff. Now, it's important to also recognize that textbooks say one thing and practice may say something different. So what we know in terms of what is ideal for oxygen saturation is that we want to see 95% and above. If you have certain kinds of patient populations, let's say a patient who's having chest pain, a patient who is admitted for unstable angina, or acute coronary syndrome, or post-MI, or other things, we actually want to bring that oxygen up to 100%. If we have to hyperoxygenate or just provide that really adequate oxygen, we may even choose to go beyond the 95. But for general population, we'd like to see 95 and above. That would be ideal. But often we say 90 and above is acceptable. We may want to apply oxygen or other things, but 90 and above is acceptable, not ideal, but acceptable. That 90 to 94 range is acceptable for adults under general circumstances. And we may even see certain patients, we'll talk about that in a second. For example, a patient with COPD who is a CO2 retainer, having an oxygen saturation below 90 as acceptable. So it could be 88 to 90, 87 to 91. The patients may have their own range, or hospitals may have specifics that tell you about the acceptable range. So understanding the difference between ideal for an adult, that's 95 and above, non-COPD. For adults, again, acceptable is typically 90 and above, but we would then implement some kind of oxygen therapy to at least get a patient to 90%. Now let's talk about specific populations just for a second. I've just talked about what's ideal versus what's acceptable. All bets are off with pediatrics. For children, ideal and acceptable are both 95 and above. Okay, so we don't go down to that 90 is acceptable, but we want to treat. For children, we really need them to get up to 95%. Now let's talk about the COPD for just a second, because there is a misunderstanding. Now, here's where we're going to differentiate again between practice wisdom and the NCLEX, or what you're going to read in the textbook. Because there is a concern that we can cause significant harm to a patient who has COPD and retains, is a COPD retainer, we often are very cautious about applying oxygen to anyone with a diagnosis of COPD. But not all COPD patients are CO2 retainers. That's the important thing to remember. There's a recommendation now that patients who have COPD and who are CO2 retainers, and even those who are not, carry a card from the respirologist. So this is a standard, that's a recommendation. They carry a card from the respirologist, just a standard card that you can hand out like you would have an immunization card that says, I have a diagnosis of COPD. My optimal oxygen saturation range is this, 88 to 100, 95 and above. If you're not, it's only a subgroup of patients with COPD who actually have the issue of CO2 retention and who cannot tolerate higher levels of oxygen. So we don't want to withhold oxygen on patients who require it under any circumstances, even with COPD, but they may require specific care. You may require a greater finesse and other things. So just to keep in mind for the NCLEX and for exams, they typically, when a patient has COPD, that is a cue to you to say, oh, watch the oxygen, O2 sats, lower O2 sats might be acceptable, and don't over apply. So don't over apply oxygen. Don't provide too much oxygen because of the risk of CO2 retention. In practice, I want you to be much more discerning. ABGs will give you insight into whether a patient is a chronic CO2 retainer or not. I'm not going to go into that now. You don't need to know it, but the physician who's looking after that patient will know that. And old chart and other things will give you a medical chart, a medical history will give you information about that. So I want you just to plant that seed for future. Not every patient with COPD is intolerant of oxygen, including high flow oxygen. It's only a subpopulation within that group. And so just to be cautious about over-representing that, but you're not going to implement something on your own without some discussion. And a good question, if you're in the middle of a situation where a patient is short of breath and has a history of COPD, is to say, is there evidence that this patient is a CO2 retainer? If people are feeling cautious that they can't implement oxygen, if the physician is feeling cautious, just to ask that question, is there evidence? And it's quite helpful. And just finally, a bullet point here, to recognize the difference between a single reading, oh my gosh, I'm so sorry, a single reading, which is a snapshot, and a continuous pattern. So asking yourself, do I see a pattern of changing oxygen saturation that tells me that we're seeing a drop, or that we're seeing that oxygen saturation going up, or do I see some consistency? And that's helpful in recognizing where a patient may be at. So oxygen saturation, like all of our other vital signs, are something that we see as a single moment in time, but it's always critical that we evaluate that within the context of what is the pattern. But let's move beyond that. I think there's a tremendous over-reliance on oxygen saturation. So if somebody has an O2 sat of 90, and Sue Coffey has said that that is acceptable but not ideal, but are they hanging on, and can we keep working towards a better O2 sat? Or let's say if someone even has an O2 sat that's higher, 93, 94, 95, is that acceptable? Here's what I want to say. We cannot look at that oxygen saturation in the absence of looking at our patient, assessing our patient for this critical concept. How hard is the patient working to get that O2 sat? And so, although we've done a pristine health assessment and including a respiratory assessment, and we look at these things, I just really want to bring your attention back to them. There's 3 indicators that are so critically important. Again, this is just a practice wisdom perspective. One is accessory muscle use, and I know you learned this. So are they raising their shoulders as they breathe? For an adult, we're raising our shoulders so that we can increase that the filling of our lungs. Are we using abdominal muscles to help us to breathe? And in particular for children, you're going to see that abdominal muscle use, right? So are they using those abdominal muscles? For children, when they're working really hard to breathe, often they'll complain of stomach pain, or they may even throw up. They'll have lack of appetite because their abdominal muscles are so tired. So accessory muscle use is really critical. You know why? Because patients get tired. It's like running a marathon, but they're lying in their beds. Accessory muscle use, regardless of O2 sat, is a critical indicator of how hard it is for a patient to get enough air in. And it's really important that we pay attention to that. When we see a patient using all those accessory muscles, immediately, again, depending on all of the other factors and what's going on, what I want to do is help the patient as much to fill their lungs with air in a passive way. We're going to talk about active ways in a second. But one thing is to put the patient in an upright position. So have them sitting up. So high Fowler's is a really good position. Again, blood pressure is okay if they can tolerate it, depending on the procedures that they've undergone, things like that. But that helps with lung expansion. So watching that accessory muscle use and asking yourself, does this patient, is this patient at risk for tiring? Because that tiring, or what we would say in just like, you know, hospital language, pooping out, happens very quickly, and a patient will decompensate right in front of your eyes. The second associated symptom is really important as well. Do we see nasal flaring? So, are their nares opening up as they're trying to get that air in? Do we see intercostal indrawing? So indrawing between the ribs. And then do we see right up here at the trachea, that tracheal tug? In particular, we see all three in children. Adults, we often see that nasal flaring first because we may have more abdominal girth and other things. We may not see that intercostal indrawing as much or that tracheal tug. For sure, kids, we look at that triad always. Adults, we may see all three, but for sure, we're looking at that nasal flaring. Also recognizing we may have oxygen on the patient, but as people become short of breath, it's very hard to breathe through your nose. And then natural response is to open your mouth and take a big breath. So watching that, are they breathing through their nose or their mouth? And if they're breathing through their mouth, applying nasal prongs is ineffective. Then finally, this indicator, how many words per sentence can they speak? And per sentence really means per breath. So here I am, I'm talking in full sentences between breaths, but sometimes I can only say one word or two words or three words, and it would sound like this. I am feeling short of, do you see I'm having to take a breath between words? Or I could say, I am feeling like I can't breathe. So 2 to 3 words. And so it's not precise. I'm not gonna watch somebody for 1 minute, but you get it. How many words can they speak between breaths? A really important indicator of what is that work of breathing. Those 3 things. Do we have accessory muscle use? Do we have those associated symptoms? How many words per sentence? And you think, oh, that's just a nursing assessment. If I communicate that to the doctor, he or she, or the respiratory therapist, he or she may not really recognize what that means. That's maybe just as kind of an informal assessment. Oh, no, this is a critically important assessment. Critically important assessment. And if you give your SBAR report and you say an oxygen saturation is 95, the doctor or the respiratory therapist or your colleague may say, okay, sounds good. If I said somebody's O2 sat is 95, but they're using all of their accessory muscles to breathe, they have the person has nasal flaring and is speaking one-word sentences, the response from a respiratory therapist or a physician is going to be, I'll be right there. Because we recognize the real risk is a person will start to decompensate and they will just poop out right in front of your eyes, or you'll be out of the room and they'll poop out. And the risk is that somebody is not going to be able to maintain that 95. So we don't want to, one of the most important things that we always say is we don't want to use up a person's time, their body, that compensatory response, using those accessory muscles, doing that nasal flaring, they're buying us time. We don't want to use up that time by ignoring it and over-relying on that oxygen saturation reading. And then just a fundamental that we always look at early intervention. So in terms of increased work of breathing, what's going on? Does the person need some kind of inhalation therapy like Ventolin, keeping in mind that we know, and it is a little counterintuitive for those of us who are old nurses, that we think, oh, it must be easier for somebody to breathe in an inhalation therapy as a nebulized therapy versus that little puffer that you have at home. But we know a puffer is much, much more effective at getting those particles right down to the bases. So we should always use puffers with an aero chamber for children or adults. And for adults, we can use it where they put their mouth around it, or they have the face mask, just like a child, if they are having difficulty doing it. We want to make sure with puffers, we can actually have quite a high dose. So again, I'm not suggesting dosing to you because that's beyond my scope. But just to give you an example, often in the emergency department, we can give Ventolin puffs 1 every minute up to 10. So we can give quite a few puffs to bring somebody some relief from that acute constriction, as let's say is associated with asthma or COPD, and quite a significant dose. And it's just that using excellent technique, have somebody inhale and try to keep their lungs expanded if they can to let those particles go down. Oxygen therapy, just a reminder from Leslie and I, 2 liters is not a magical amount. Often there are standing orders or order sets that allow you to apply 2 liters of oxygen. It's not magical. That's not magical in any way. What we want to do is apply oxygen to response. And some, again, I would say moving beyond 2 liters, we want to apply oxygen to response. If that's all you are allowed to apply, without an order, then you need to look at what a patient's SAT is, how they're responding to oxygen, what the work of breathing is, and be prepared to move beyond that. And if that requires that you get an order, go ahead with that. There's a new kind of oxygen that is applied externally, so it's not invasive, but what it does is it applies oxygen with force, and that means that you're not in a regular face mask, oops, sorry, that's my daughter, face mask or nasal prong oxygen. The patient has to use respiratory effort to breathe that in. The oxygen doesn't passively go into your lungs. With oxyflow, it actually has a force, it's just nasal prongs, but has a force, I think it might be a mask as well, a force that pushes that oxygen in. And that can make a huge difference when we're thinking about that basic measure of work of breathing and the respiratory effort. How much effort does it take? We also want to look at BiPAP or CPAP. We see that a lot in hospitals now. Again, a game changer in the last 15, 20 years in helping to stave off intubation for patients, because what that does as well is decrease the work of breathing by forcing that oxygen in as opposed to that passive process. It can buy us time. So BiPAP on its own doesn't typically turn a patient around. What it does is it buys us time to overcome whatever the underlying situation is. So to provide medications, inhalation therapy, or steroids, intravenous steroids, or other kinds of medications that will help to correct the underlying problem. And then finally, intubation. Intubation is a process whereby we assist a patient through mechanical ventilation. Patients who are intubated would typically have to go to an ICU and be provided with one-on-one or one nurse to two patients care. They would be sedated, and most often sedated and paralyzed, and you would watch for both. And again, you would buy time. The thing about intubation is that for some patients, it's quite difficult to extubate them. So once we've intubated a patient, it's hard to get them off the vent, particularly patients like someone with COPD. Patients requesting full care, we absolutely would move forward with that. But when we're looking at the quality of life and the likely outcome of things, for some patients, again, this early intervention, it doesn't mean we're withholding treatment, we're waiting till the last minute to decide to intubate. In fact, what we want to do is be highly aggressive at an earlier point, looking at these other options like oxyflow or BiPAP that are going to really help the patient with that work of breathing so they're not so profoundly exhausted. In all situations, what we want to avoid is watching a patient use up all of their effort and get to a point where they're having a respiratory arrest or close to a respiratory arrest because we haven't acted early enough. So keeping in mind, we want to really pay attention to all of those parameters. We want to pay attention to our oxygen saturation, but not over rely on it. We want to look at that respiratory patterns and do a pristine health assessment, including a respiratory assessment. And then finally, we want to look at those measures of work of breathing and document them well, and communicate those effectively, keeping in mind that our goal is early intervention. I hope that has been helpful, and I will talk to you again soon.